Muy buenas tardes. Bienvenidos al último seminario web de este año, titulado Update to Type 1 Glutaric Aciduria Guidelines, dictado por el Dr. Nikolas. Esta instancia ha sido organizada en conjunto por la Sociedad Latinoamericana de Errores Innatos del Metabolismo y Pesquisa Neonatal y el Laboratorio de Enfermedades Metabólicas del Instituto de Nutrición y Tecnología de los Alimentos de la Universidad de Chile. La conferencia se realizará en inglés y durará 40 minutos. Luego tendremos 15 minutos para resolver sus dudas, por lo cual los invitamos a realizar sus preguntas mediante la opción Preguntas y Respuestas de la plataforma Zoom o a través del Facebook de SLEIMPN. Good afternoon. Welcome to the last webinar of this year, titled Update to Type 1 Glutaric Aciduria Guidelines by Dr. Nikolas. This space has been organized by Latin American Society of Inborn Error of Metabolism and Newborn Screening and the Institute of Nutrition and Food Technology of the University of Chile. The conference will last 40 minutes and then we'll have 15 minutes to answer your question. We invite you to do your question through question and answer option in the platform or through by SLEIMPN Facebook. Este seminario estará moderado por la doctora Carolina Arias, quien es médico especialista en neuropediatría, profesor asistente de la Universidad de Chile, parte del equipo clínico del Laboratorio de Genética y Enfermedades Metabólicas del INTA de la Universidad de Chile. This webinar will be moderated by Dr. Carolina Arias, who is a physician specialist in neuropediatrics. Dr. Arias is assistant professor of University of Chile, and she is part of the clinical team in the Laboratory of Genetics and Metabolic Disease from INTA University of Chile. Dr. Arias, you can start with the webinar, please.
Good afternoon to everyone. Today is a pleasure to introduce Dr. Nikolas. He's currently working as a consultant for pediatric metabolic medicine and child neurology at Children's Hospital in Heidelberg since 2009. After his specialization in pediatrics in 2014, his main scientific activities has focused on metabolic medicine, specifically in glutaric aciduria type 1. Since 2015, he's the coordinator of the glutaric aciduria type 1 guideline group and has coordinated 2 guidelines revisions. In 2023, he was nominated as a professor for pediatrics by the Medical Faculty of the University of Heidelberg. His current main research activities comprise long-term outcome and disease variant in glutaric aciduria type 1 and other organic acidurias, as well as urea cycle defects. Furthermore, he is the study site coordinator for the Patients Registry and Natural History Study within the German Network for Mitochondrial Disorders. So thank you, Dr. Boy, for joining us today, and you can start your conference, please.
So, hello everyone. Good afternoon. It's a great pleasure to join your conference and to join your webinar tonight. I hope you all can see the presentation, and you already heard about the topic that we have today. So I'm going to talk about the recent GA1 guideline revision, but I also give you some insights into some present research projects and also some background information. I have no conflicts of interests. So that's the agenda for the next about 40 minutes. Give you a short introduction because I think not everyone is similarly familiar with GA1. I will talk a little bit about the methodology, how we actually do a guideline revision. I will show you the newest recommendations and also what I think are the most important recommendations. We're going to discuss the impact of guideline on clinical outcome, because I think this is very important. And also at the end, I will show you a little bit the historic development of the guideline in the shape of also accompanying clinical research activities. So GE1, just a little background, was first described by Stephen Goodman. He passed away just some years ago. So it's an incidence of about 1 to 100,000 newborns. In Germany, we started screening for GE1 already 25 years ago almost. And since 19 years, it's in our nationwide newborn screening panel. In Europe, most of the countries nowadays screen for GA1, but this has been a very long development. And I'm aware that in South America, this is very, very rare that there is a newborn screening for GA1. There are several high-risk populations in the world with a very, very high prevalence that you can see here, distributed all over the world. Just the metabolic pathway, I'm sure you may know it. Still not completely understood, the lysin metabolism today, but it's located in 3 different compartments. You see the mitochondrion in the middle, you see the peroxisome, and the cytosol is around it, and you see the metabolic block down there of the glutaryl-CoA dehydrogenase, resulting in increased concentration of glutaryl-CoA that is forming glutarylcarnitin that we use for the screening, but also forming glutaric acid and 3-hydroxyglutaric acid, both known to be neurotoxic in various ways. And we also separate 2 different biochemical subtypes known as the high and the low excretors, and they are reversely correlated with the residual enzyme activity. So high excretors have very high amounts of glutaric acid in blood and urine, and low excretors have low or even no normal concentrations. Just some genetic background information. So nowadays, there are over 200 genetic variants actually described. If you check the human gene mutation database, you have homozygous variants, but also compound heterozygosity is very, very common. Genetic analysis is able to really detect almost all patients, but there is still some patients with unclear genetic results that will have to be examined by enzyme analysis and leukocytes. Very importantly, for some GCDH variants, there is a correlation with the biochemical phenotype, so the high and the low excreting phenotype, but not with the clinical phenotype and the risk for striatal injury. So this is very important to know. And what we also observe more and more after introduction of newborn screening are heterozygous patients. And some of these heterozygous patients even end up with elevated 3-hydroxyglutaric acid concentrations. But in general, the heterozygosity is not considered clinically relevant normally in patients. So the disease is a very devastating disease that I'm sure you know. Everyone who's treating GA1, symptomatic GA1 mainly, as you do it, we know there are these 2 onset types of striatal injury. On the left, you see these acute onset, acute encephalopathic crisis, normally within the first 3 years of life, resulting in severe bilateral striatal damage that you can see on the MRI on the left side. And the movement disorder is mainly severe in these patients. And on the other side, on the right-hand side, you see the insidious onset. So patients who do not suffer from an known crisis event, but show a slow, continuous neurological deterioration over time. We observe both of these onset types, both in high and low excretors, to a similar amount. So both are similarly affected. So these events are very, very, of course, important clinically and prognostically. And it's very important to stress that the prevention of this striatal injury is always the main goal of treatment in GE1. In addition to the striatal injury, there are also extrastriatal abnormalities that are found in GE1. On the left-hand side, you see a patient with frontotemporal hypoplasia This is very characteristic for GA1, but this can normalize over time. So all these MRI pictures on this left-hand side are of one patient, and in the very bottom line, you see that frontotemporal hyperplasia has actually resolved completely. On the other side, we observe white matter disease very, very frequently. And just recently, also another entity has been described. It's the subependymal nodules that are located at the roof of the ventricles. And they are observed very frequently, especially in high excreting patients and especially in late diagnosed patients. All these extrastriatal injury patterns are dynamic. Some of them are reversible, and as I already said, more pronounced in the high excreting phenotype group. Just one word to the methodology, because this becomes more and more important. So the GA1 guidelines started in 2007, and we have performed 3 revisions so far. We aimed at maintaining the highest quality level that you can reach as a guideline, also in our national guideline consortium, which is called AWMF. So we maintained the highest S3 quality level. We used the GRADE method that you see here on the right-hand side. GRADE always starts with an outcome-based and endpoint-based systematic literature research. Then you have to create evidence profiles. You can down and upgrade evidence and strength of evidence to very strict and standardized certain statistical criteria. Then you have to end up with a final strength of evidence. And of course, then you have to discuss the most important key questions with your guideline group. You have to formulate recommendations. And now this is very important, and you see it on the very low left side of the figure. You have to discuss not only the strength of evidence, but a lot of other criteria that are important for healthcare, for a certain recommendation, such as what is the balance of benefit and harms for the patient? What are personal preferences of patient organizations, for example? What are economical and social considerations? So you have to discuss each point for every recommendation, and then you end up with a certain level of recommendation. We had 24 members, 13 professional societies, also involving the patient support group. We had different working groups, several meetings, and then we had a long standardized review process. And now the work has been finalized since 2.5 years almost. What is new in the recent revision? So we have increased evidence on the efficacy of newborn screening and metabolic treatment. We have modified and specified almost all of the recommendations, and also some new recommendations have been implemented on arginine, the extrastriatal abnormalities, vaccinations, and transitions also. I was talking about striatal and extrastriatal pathology in GA1. Another thing that I have not mentioned is that GA1 patients are also have an increased risk for subdural hematoma, so for cerebral vascular bleedings. It has been proposed that this is something that is only happening in symptomatic patients, for example, after an acute encephalopathic crisis. But actually, our MRI prospective study has shown that this is actually occurring in all kind of GA1 patients, the symptomatic ones, but also the asymptomatic ones, as an incidental, mostly non-traumatic finding without any clinical differences, mainly within the first 3 years of life, and exclusively found in the high excreting patients, and always associated with these characteristic extrastriatal abnormalities. So this was something that was an interesting finding, and it's actually resolving in almost all the cases that we actually were able to follow up. And this had direct influence on the guideline recommendations regarding targeted diagnostics. So if you have a child with a subdural hematoma in combination with these extrastriatal abnormalities, you really should check for GA1. On the other side, if you have a known GA1 patient who suffered from a head trauma, even if it's a minor or a mild head trauma, you should take this child to hospital and then really admit him and check for the child at least for 24 hours. So this is the diagnostic algorithm. So newborn screening here is the main path into the diagnostic. In your place, it's the targeted workup due to clinical symptoms. It always starts with the analysis of glutarate carnitine, of course, and the organic acids. If you have elevated 3-hydroxyglutaric acid, you actually start treatment, you check the genetics, and as I said, in some patients, you also will have to do enzyme activity testing, but this is limited to just a few laboratories, actually. So I only know 2 laboratories who are able to do enzyme analysis. Treatment principle is actually a simple principle for GA1. So the idea is we lower the lysin intake by nutrition, we lower the cerebral lysin oxidation, we lower the accumulation of metabolites, and thus improve the outcome. And this is actually working. This has been shown in the mouse model that you see here on the right-hand side. So you see, according and depending on the extent of lysin reduction, you end up with a reduction of GA concentration in both brain and liver. But you also see that if you administer lysin too low, so the amount of lysin intake is too low, then you end up in malnutrition and also in growth disturbance. So this is, of course, something that we do not want for our patients. So you have to give your patient lysin. You cannot give him 0 lysin, but it has to be, limited as much as possible. This is already the recommendation for the dietary and also the maintenance treatment for GA1. I have highlighted the most important things in blue boxes. So with the maintenance treatment, of course, it should be supervised by a specialized center. There's data that shows that patients managed in centers have a better outcome than those who are not. Very, very important recommendation is recommendation number 6. So the low lysin diet is strongly recommended in all patients up to the age of 6 years in combination with the amino acid mixture, who should be lysin-free, tryptophan reduced, and arginine enriched. Both of these recommendations, as you see on the left-hand side, are strong recommendations with the highest level of recommendation A. A B recommendation is the carnitine supplementation. So this is also important, but the effect of carnitine is less clear compared to the dietary effect. Of course, also emergency treatment is important, and I'm going to talk about this in just a minute. This is an overview of the metabolic maintenance treatment recommendations. So you see here the different age groups. You see the amounts of lysin, of amino acid, protein, energy, and carnitine. And you can also see that at the age of 6 years, the dietary treatment is switched from a strict low lysin calculated diet to a liberalized protocol that we call controlled protein intake. And I'm going to show you what this is in just a second. Very practically, because a lot of dietitians also attend, as I hear. So this is how the dietary treatment looks like in the first year of life. So in the first months, we combine breast milk or baby formula with the special formula, which is lysin-free and tryptophan reduced, but also contains fat and carbohydrates. And then once more and more solid food is introduced, then we use additionally low lysin foods that you see here on the left-hand side, and then we switch to the lysin-free amino acid supplement. And once the child is a little bit older, this is a example plan at the age of 3 years, we actually choose solid food from different kind of food groups, lysin-rich to a very limited amount, medium lysin content group, but also, of course, and mainly the low lysin or lysin-free groups that you see here. And this is, of course, always combined with the amino acid supplement. Another thing that is important for treatment is arginine. Arginine, why are we using it in GA1? This is a model of the blood-brain barrier. You see the blood at the top, the brain at the bottom. And the idea is that arginine is competing with lysin at the blood-brain barrier, specifically at the CAT1 transporter. So if you administer arginine, then the lysin intake can be reduced into the brain. And thus the accumulation of neurotoxic metabolites within the brain can be reduced. And this is really working. So this has been a hypothesis for the mouse model also, and has been checked if there is an additional positive biochemical effect of the arginine supplementation. And this is something that you can see here on the left-hand side. So yes, there is an additional effect of arginine in addition to the low lysin diet, but you also see that the effect is much less than the effect of the lysin reduction. And you also see that you need very, very high amounts of arginine, so supraphysiological amounts of arginine to actually end up in a little additional biochemical effect. Okay. But of course, this led to clinical implementations. So we asked ourselves some years ago, is it making a difference for the patients how many arginine he or she is actually receiving? And we were comparing two groups that we had in our cohort receiving different amounts of arginine depending on the type of amino acid mixture that they were using, and they were different in the arginine amounts, especially in the first years of life. And we were comparing these two groups, and you can see the result on the right-hand side. There is no difference. The outcome of both groups was very positive, normal. They showed normal neurologic development. All of these are newborn screening patients. It didn't matter what kind of amino acid mixture they were taking. So taken together, the amount of arginine that we give our patients with the low lysin diet, with the amino acid mixture that is arginine enriched, and also, of course, via the endogenous synthesis that GA1 patients are having because their urea cycle defect is working completely normally, this arginine intake is associated with a very positive and beneficial outcome. So the amount is actually obviously sufficient. So there's no need for an additional oral supplementation as you do it in an urea cycle defect, for example. And this was something that we implemented in a new recommendation number 8 here. No evidence for an additional arginine intake orally. Now you can ask yourself, why is it actually necessary that we still continue the lysin reduction after the age of 6 years? Because the crisis and the insidious onset events, they don't happen anymore after the age of 6 years. There are several important factors for that. First of all, if you look at patients, especially late diagnosed patients and the older ones, you will see that the older the patients are, the more significant and severe the neurological symptoms are. So in this cohort here, I hope you can read it. The oldest patients had, for example, tremor, dementia, epilepsy, everything. So they were much more affected than the younger patients. Of course, this is a small cohort, but it gives an idea that really the older patients may show more severe symptoms. The next thing I already mentioned are the extrastriatal abnormalities, the subappendicular nodules. They are progredient with age, so they are increasing in their extent. Another thing that has been observed and described are malignant brain tumors. There are 3 case reports out there at the moment, and I know of a 4th patient. All of these patients, it's important to stress, have not been treated with guideline recommended treatment. And it's completely unclear whether, for example, the subependymal nodules are a precondition for the brain tumors or if they are somehow connected. It's something that we do not know, but it's something that we have to include into our monitoring. And the last one is that recent data of the EIMG registry has highlighted that also kidney function can be a problem in some, especially adolescent and adult patients. And we checked for this in our newborn screening cohort, and we also observed a slight decrease of the kidney function, not to an extent that you will see in an MMA patient, but to a slight decrease. But this is something that has to be further examined. So especially the manifestation in the middle has led to this new recommendation that since there may be a clinical implementation or consequence, for example, if you have a clearly progredient mass in the brain, you should check for extrastriatal abnormalities at the age of 10 years and then repeat it depending on the results. But you also see on the left-hand side, the evidence grade here is very, very low. So this is a recommendation for research, open recommendation. Another point and factor to continue treatment is some new data, and this is something I wanted to show you because it's not been published yet. So we are currently analyzing also the peripheral nervous system because polyneuropathy has been described in very, very single patients. So we are checking in our cohort for this, and these are mainly patients from selective screening, so not newborn screening, but we also have some newborn screening patients. And here you see the low excretus, and taken together, if you check the sciatic nerve here, you don't see any differences. So the healthy control looks exactly the same as the low excretor patient. And here you can see the high excretors that do show clear morphological disturbances. So we are currently doing the analysis with the neurophysiology, so we don't have the results of this yet, but this is evidence that there is ongoing neurological damage even outside of the striate and in the high excreting patients. So on the other side, as I said, we are able to liberalize the dietary treatment. Why is that the case? I just told you that there are no reports of acute or insidious onset after the age of 6 years. Most of the crises occur in the first 3 years. The second thing is, and this is very important, all these abnormalities that I was just talking about, extrastriatal renal abnormalities, we do not know what the clinical relevance of this actually is for the patient. We do not know if there is a problem of the white matter abnormalities, if there is a problem of the slight GFR reduction. This is all under current research still. And we also know we cannot prevent it even by early treatment. And last but not least, the cognitive phenotype that we have analyzed some years ago, that you can see here with low excretors on the right-hand side showing very stable and normal cognitive functions. The high excretors showed lower cognitive performance compared to the low excretors. And even in this cohort, we could not prevent this cognitive, slight cognitive disturbance in the high excretors by treatment. So taken together, after the age of 6 years, you should check and switch from the low lysin diet to the protein controlled diet. And this is some practical background information. So the protein controlled diet mainly consists of using low lysin food and only using lysin-rich food to a limited amount, but you need some lysin-rich food, especially in order to maintain sufficient supply of high-quality protein, of minerals, of vitamins. So there is a green group on the very left-hand side you can use without any restriction. You need the group in the middle, the yellow group. So animal products, for example, to a certain amount, and you can find here in this table exactly the amounts that are recommended for the different age groups, including the adult patients. And there are also, of course, some unsuitable food groups. So this is an example plan for a 6-year-old, for example. You see here, most of the items are lysin-free or low lysin groups, but some of the food that is used is from the intermediate, from the yellow group. So as you are treating a lot of dystonic patients, I also included some information on dystonic patient treatment. So first of all, the treatment recommendations are also, of course, recommended for these patients, acute onset, insidious onset patients. You have increased morbidity, of course, in this cohort. You have problems like orofacial dyskinesia, feeding problems, growth disturbance. The energy demand may be decreased or increased. So you need individual concepts. Very, very importantly, you have risk of catabolism in dystonic crisis, for example. So something that can be checked, for example, are ketones or electrolytes in these situations. You should adapt all the essential nutrients, minerals, etc., according to individual needs and according to the clinical situation of your patient. You may need tube and gastrostoma feeding in a lot of them. You will maybe need to use semi-solid food with low lysine content, for example. We sometimes also use the amino acid mixture even after the age of 6 years, just to maintain sufficient energy supply. Of course, fluid quantity is important. Late meals can be introduced. So there are several practical ideas here how to guarantee treatment in severely dystonic patients. But I think the most important thing is careful nutritive and clinical monitoring in these patients. We have summarized all this in parental guides that we have developed in parallel to the guideline. We also have revised this some years ago, and we also translated it in several languages, including a Spanish version. So you can check this webpage here that I highlighted in blue, and you will get a PDF that you can print out, and you will have a lot of information on GA1 and very practical dietary information especially. Talking about emergency treatment, I already have told you that it's very, very important, and it's strongly recommended up to the age of 6 years in all the patients. This is something that has not been changed. And after the age of 6 years, we do not know what the clinical effect is. We recommend it for severely affected children, severely ill children, or if you have perioperative management. But you can see it's a recommendation for research recommendation, so the level of evidence is very low. So coming to the next chapter, outcome effects of treatment. So nowadays, the situation has changed dramatically after implementation of newborn screening, but still, as you see on the left-hand side in the low, patients suffer from crisis nowadays. And of course, if you have no newborn screening, you only have patients that are severely neurologically affected. So, but we asked ourselves, how is the current situation in a newborn screening cohort that you follow over 25 years? These are some results that we obtained here. So we included almost every patient that we screened since 1999 in the country. We ended up with 87 correctly identified GA1 patients, and about 2/3 of them remained asymptomatic over a very long observational period. So this was a very positive outcome. But as you see here, 1/3 is still symptomatic, about the half of them acute onset and the other half insidious onset. 4 patients were missed by newborn screening. But I want to talk about these huge group of asymptomatic and symptomatic patients. And we asked ourselves, what are the most important factors that decide if you remain asymptomatic or become symptomatic? And we learned this is treatment quality. So adherence to emergency treatment and maintenance treatment are the most important prognostic factors. If you adhere to both of them, you will end up in prevention of striatal injury in almost every patient, over 90%. If you don't have emergency treatment adherence, you will always end up in movement disorder that is mainly severe. But if you do not adhere to maintenance treatment, then you end up in an increased risk for this milder, so the insidious onset dystonia. So very important, treatment quality is really the most important thing in G1. But only 2/3 of the patients really are treated according to the recommendations in our cohort. So there's a lot of room for improvement. Also, the US cohort had very similar observations. So you also see here the cohort treated with low lysin diet and amino acid mixture after newborn screening shows by far the best neurological outcome compared to other types of dietary treatment as low protein diet, for example, or targeted screening, of course. We also did a meta-analysis on that. We included over 600 patients worldwide, and we also could clearly demonstrate the positive effect of newborn screening that is dramatically reducing the frequency of movement disorders, but also on the other side, showing that if patients do not receive the low lysin diet, but any other form of dietary treatment, they have an increased risk for the insidious onset dystonia. It's once again highlighting really newborn screening and guideline according treatment are the most important and or most beneficial interventions for GA1. Dietary treatment is safe. We observe a very stable anthropometric development in almost all patients, except the severely dystonic patients. They show clear growth disturbance, but in the other patients, we see a very positive outcome, and this once again highlights the importance of emergency treatment. This is also some unpublished data so far in our newborn screening cohort, highlighting laboratory long-term outcome. You see that almost all of the basic laboratory parameters are actually within the normal reference. You see that the lysin concentration is increasing a little bit because we are liberalizing the restriction. Arginine is very stable. Glycine is elevating. This is an interesting observation, and the free carnitine is decreasing a little bit because we also use reduced dosages. And importantly, of course, we see very, very stable clinical development in the patients. So this is the last chapter. The guideline of GA1, as I said, began in 2007. And in the very beginning, we had very basic questions, and every guideline revision had its new key questions. And in the beginning, we were asked ourselves, is newborn screening an effective intervention? Is there at all a treatment for this disease? What kind of treatment should we use? And there was very, very low evidence. And in accordance, the level of recommendations were very poor at the beginning. But a lot of observational prospective long-term studies have accompanied this process, and they help to answer these key questions and continuously increase the level of evidence and to answer the key questions. So this is something that really is, I think, unique about the GA1 guideline. These studies have helped us really to understand what is the effect of our treatment, and also to identify risk profiles if specific treatment adherence is not fulfilled, for example, and also improve level of evidence. This is something I think which was very, very important. And I just show you an example for treatment. So you see dietary treatment at the very beginning, a very poor level of recommendation, GCP, and now since the last two revisions, we have grade A recommendations. Emergency treatment at the very bottom was a very weak recommendation in the beginning, but also continuously improved, and now is a very, very strong recommendation. Also, the request is continuously increasing. Of course, this is something that that is very positive. So we also, of course, do this guideline to be implemented as much as possible, and to really to improve outcome worldwide as much as possible. And I summarize this in kind of an evidence-based treatment pyramid. So what are the most important factors in GA1? Emergency treatment before the age of 6 years. This is very, very important, and it's number one, directly followed by the low lysin diet with amino acid mixture beyond the before the age of 6 years. So both within level A, both followed by carnitine and the protein controlled diet, both with a level B recommendation, and then we have emergency treatment above the age of 6 years and arginine with a level 0 recommendation, and riboflavin is not recommended. So this is the last slide, or almost the last slide. This is the summary, actually. So we have 24 mostly modified recommendations in this recent revision. We have new recommendations on arginine, extrastriatal monitoring that I was showing you. I did not speak about vaccination and transition. Newborn screening and guideline according treatment, especially emergency, but also maintenance, of course, are very, very effective and by far the most effective interventions and most important prognostic factors, far beyond any kind of biomarker, for example. But there's room for improvement. It's increasing evidence, as I showed you, which is very important for a guideline development. And these studies help us to really improve the guideline continuously. But still, there's a lot of open questions, especially, for example, regarding treatment that are highlighted here. So the intensity of lysin restriction is still unclear. What is the optimal intensity? What are the indications for emergency treatment in adolescent and adult patients? I'm sure you also asked that yourself in these situations. And I think this is also a very, very important and interesting question. What is the clinical relevance of all these abnormalities that we observe in the patients outside of the striatum? This is also very important. So with that, I'm at the end. I want to thank you, of course, for your attention. I'd like to thank the guideline group that you see here. It's a lot of work, but I think it was worth it. And you can find the publication in the JMD. And now I'm happy to take your questions. Thank you.
So then, thank you, Dr. Boy, for your excellent presentation. Very interesting. And also you share with us a new pathology. So thank you for that. And there are some questions from the audience. So the first one is about the pregnancy, about how was the medical and nutritional management in pregnancy in these 3 patients that you mentioned before?
Well, I don't know if that was made up clear by myself. So there are no really specific recommendations for pregnancy in GA1. So if the question is focusing on the indication of emergency treatment in a pregnant woman giving birth, then there is no really good data on that. So there are some reports on emergency treatment accompanying a birth, and then everything went very normally and there were no complications. But there are also reports of birth processes without any metabolic emergency treatment, also resulting in no complications. But these are only case reports. There's no systematic data on that. Yeah.
Okay, thanks. I think the question was regarding your recommendation about the medical and nutritional management in pregnancy women.
Well, there is
you approach to this?
It's an interesting question, but and we do not have a lot of experience with it, I have to say. Very, very single patients that we really that we manage with the pregnancy. Of course, a lot of the late diagnosed female patients, so the patients that are not found by newborn screening. We detect these patients at the age of 20, 30, 40, and they often are mothers who had given birth some years ago, and at that time they didn't know anything about their GA1 diagnosis, and everything went completely normally, and the children are usually not affected by GA1. If we have in a single patient that we followed some years ago, we did a very careful nutritional management, but there is actually no specific recommendation for a specific lysin intake or a specific carnitine concentration. We monitor the same parameters that we use in any other patient, but we do it a little bit more frequently. then we try to maintain everything in the target ranges.
Hey, thank you, Dr. Boy. Another interesting question is there any biochemical marker in the neonatal screening to identify that third of patients that will present symptoms anyway, neurological symptoms? Could any kind of machine learning help with this, or maybe a metabolic profile? There's any biochemical marker that can predict this third of patients that don't have the better evolution?
Thank you. Yeah, very good question. The first marker, of course, is the glutaryl carnitin, and as I said, newborn screening detects all the high excretors and detects almost all low excretors. So we have quite a good specificity, but it's not perfect. So we miss some low excretors. And also, I was talking about that the high and the low excretors show the same risk for striatal damage at the very end. So regarding this most important prognostic event in a GA1 patient, there is no difference between a low and a high excretor. So you cannot tell any prognosis according from the concentration of glutarate carnitine or the concentration of glutaric acid or 3-hydroxyglutaric acid within the urine from the very beginning. On the other side, recent data is supporting the hypothesis that there is a certain difference between high and low excretors, but it's not regarding the striatal damage, it's regarding the extrastriatal pathology, but in that we do not know what the clinical relevance is. High excretors show more macrocephaly and enlarged head circumference, but this is also something that has no clinical relevance. We do see a cognitive difference. So this is something that you maybe at least can use a little bit as a prognostic factor in terms of psycho or cognitive development. And the bleedings, the subdural bleedings that we observe in the patients aged until the age of 3 years are also exclusively found in high excretors. So we have never found a low excretor with a subdural hematoma. So there are differences, but the clinical relevance is just about to emerge in the recent years. But again, the most important prognostic factor is the striatal damage, and this is completely similar in high and low excretors. So newborn screening cannot give this very important answer at the very beginning. Regarding the machine learning, that's a very good question, and we are also currently doing projects on that together with colleagues from Mathematic Institute, because I think what is important is we have to improve the false positive rate of in newborn screening. We accept a very, or compared to other diseases of newborn screening, we accept quite a high frequency of false positive results because we do not want to miss any low excretor. But this is something we have to improve, and we try to use machine learning for that, but we are just directly in analysis, so I cannot give you any results of that so far. But it's an important project, and I hope I can give you some answers next time.
So thank you. Another question is about your experience in the management of movement disorder, because in countries without newborn screening, after the encephalopathic crisis, there is a severe movement disorder. So the neurological management and the neurochirurgical management of these conditions, like deep brain stimulation or pallidotomy. What is your experience in these cases with severe movement disorder?
This is a very difficult question. We could do an own conference on that. Well, to give a short answer, there is not the best medication that I can recommend to you right now, and you will have positive effects in all of your patients. It is unfortunately really very, very, yeah, individually different. There are medications where we have more experience than others. For example, with baclofen, with gabapentin, with tolperisone, we have a lot of experience. There are more and more other medications that come into treatment for antidystonic effects, such as clonidine or dronabinol, for example. But oral medication still in a severely affected patient is very difficult. The experience with neurosurgical interventions is very, very limited. There is only really a very low number of patients that are being published with very heterogeneous results. So there is not the specific intervention that always ended up in positive results. There are, I would say, between 5 to 10 patients being published, and some showed slight improvement, for example, with deep brain stimulation. Some did not show any effects, and some even showed deterioration after the surgery. So it's still something that you have to decide individually. We do not have a lot of experience with that in our own center. We cooperate here with other centers. For example, in Montpellier in France, they have a lot of experience with deep brain stimulation in all kind of neurological diseases and metabolic diseases. But also with J1, they only have 2 or 3 patients, and none of them had a really beneficial outcome. So I think what we are using more and more are baclofen pumps, so intrathecal baclofen pumps, where we see positive effects if you manage to avoid the complications. But this is something that may help. But yeah, also here, the strength of evidence is very low. We have included a chapter on that in the guideline. And there you see all the different medications, for example, and also the recent findings on the surgical procedures. But it's still you need a good neurologist and maybe also a neurosurgeon, but I think the most important professional is the neurologist.
So thank you. Another question is about riboflavin supplementation. Can you comment on that, about riboflavin? Do you think?
Yes, well, there is just it has been hypothesized that there may be a response or an increase of the activity of glutathione dehydrogenase after supplementation of riboflavin. But the evidence is very, very low. There is no standardized protocol how to test this at all in a patient, similarly to tetrahydrobiopterin and PKU or something. So there's absolutely no diagnostic tool to assess it. And the data are quite clear that clinically you do not see any effects of patients. You also do not see any effects of biochemical or decrease or amount of elevation of glutaric acid or 3-hydroxyglutaric acid. And even if there would be, we have learned that the role of glutaric acid and 3-hydroxyglutaric acid for monitoring is very, very low and is not recommended actually. So taken together, there is no evidence for a clinical benefit of the riboflavin supplementation. So it's not, it's actually not recommended. What you can do where riboflavin may have some kind of role is if you have patients that need a lot of carnitine and they develop carnitine side effects. For example, the fishy odor in carnitine. Some of them profit from riboflavin supplementation. So then the fishy odor is reduced. But in a general patient, it's not recommended for riboflavin supplementation.
So thank you, Dr. Boy. I'm really sorry. One last question. I know we are in time, almost in time, but one last question about extra neurological impairment at follow-up. Do you suggest? I guess the recommendations include, renal function, but do you think we need to monitor more another pancreatic involvement, for example, or there are recent reports about auditory impairment too in this group of patients? I don't know if you can include this in the follow-up at long term. We monitor another organic aciduria that have a mitochondrial impairment or energy production. Do you think we are going in that way in GA1?
Well, I think the interesting thing about GA1 is really it's a really emerging and continuously developing clinical phenotype, and this is something that we really learned from the observation of this screening cohort, that the phenotype is changing with time, and anytime we look at the patient systematically, we learn that there's something new coming up. I think the renal phenotype is really a manifestation that is evident, but again, the clinical relevance is still unknown. There are only very single cases of really severe renal insufficiency. But for example, dialysis was not necessary in any of our patients. So I think we need much more data to really elucidate what is the amount of this renal disease, what is the dynamic of the renal disease in GA1, to really specify the recommendation more. Now it is recommended to check the renal function starting from the age of 6 years and then do this yearly. This is the best that we recommend at the moment. But we also plan to look into our cohort again next year. And then we also want to highlight the renal function again. Regarding other organ manifestations, absolutely unclear if there are any other organs that are also part of the phenotype. I do not know of any patients that have, for example, developed pancreatitis or something. So this is not recommended at the moment. But regarding the neurological phenotype, yes, there are some reports of the hearing problems. The evidence strength is still low, and it's primarily observed in the clinically diagnosed patients. So, for example, if the early treatment patients also do show disturbances in hearing function, is unclear. So I think also here we need more data to really specify these recommendations. So in the very recent revision, we did not include a specific recommendation, for example, for hearing, but maybe next time.
Yes, thank you, Dr. Boy. Very good answer to our questions. They are very difficult. So thank you very much. And for your participation in this conference and your collaboration with us. Now we are going to close this meeting. Thank you, Dr. Boy.
Thank you also. Thank you very much. It was a great pleasure. And feel free, if anyone still has a question that was not able to be discussed here, write me an email or I'm happy to answer. So thank you very much.
Thank you for your disposition. Yes.
Thank you, Dr. Arya and Dr. Boy, for this interesting webinar. Y les agradecemos a todos su participación, tanto en el seminario web de hoy como en los que pudimos realizar durante todo este año completo. En nombre de nuestra presidenta de SLEIMPN, la doctora Ida Lemes, los dejamos invitados desde ya para que puedan programarse al 13º Congreso Latinoamericano de Errores Innatos del Metabolismo y Pesquisa Neonatal, Tendiendo Redes, que se realizará del 22 al 25 de octubre del año 2024 en Punta del Este, Uruguay. Por nuestra parte nos despedimos, les deseamos unas felices fiestas de fin de año y esperamos volver a encontrarnos el próximo año. Les damos las gracias, el equipo del INTA y de la Sociedad Latinoamericana de Errores Innatos del Metabolismo y Pesquisa Neonatal. Hasta la próxima.